will join us later.
Okay.
Thank you so much, Dr.
Okay.
Hartley, for joining us today. Actually, we have a lot of problems diagnosing and managing acute otitis media in pediatrics, and when Dr. Tavasoli told me that we can have your perfect presentation, I was very happy because as an assistant professor for 4 years, I've been teaching this very important subject, and I myself have all the time problems. So it's a great honor for us. Thank you, and we're all ears.
Okay, well, thank you for having me. And this is my first international lecture, so I just wanted to give a salute to all of you trying to help the health of children in Iran and perhaps other countries. I think one of the things that's nice about being a pediatrician is you focus on kids. And I think if you got the kids from America and the kids from Iran and put them all in a place with a playground, they would have a lot of fun together. And the pediatricians and scientists can also get along, and too bad maybe someday the politicians in both countries will figure out a way to get together. But it's my pleasure to make a tiny contribution to, if I can, to the children of Iran. So I'm just going to start with a common scenario here in the United States, and it may be common in other countries too. But how many of you have ever had a situation like this? So you're in the ER as an intern, or that stands for emergency department, and you've got a child with a temperature, low-grade fever, and so the intern then goes and presents to his attending physician, and the attending physician listens to the whole presentation. They say, "Well, is there any source for the fever?" And the intern says, "Well, his exam's normal, it's just a fever." And then the attending asks the intern, "Well, what about the ears?" And the intern says, "Well, they're not bad." And then the attending goes in and examines the patient. He says, "That left tympanic membrane is red." So then the resident says, "Okay, which antibiotic do you want me to write for?" Okay. Has this ever happened in your experience in around?
Every day
Yeah,
in
okay,
the
okay,
hospital.
okay. So anyway, if Slido worked, I was going to start off by just asking, and we can use the chat for this. So what would you say would be the biggest challenges to making an accurate determination whether a patient's going to benefit from the diagnosis and treatment of a middle ear infection? It's easy to diagnose it. You just tell the parent that they've got it. But how do we actually know who's going to benefit and who's not? So go ahead and see if we can get the chat to work to put in what you say would be the common challenges to making uh, a accurate diagnosis.
Okay, it's okay for you. I'm going to translate these short questions for guys. So maybe
Sure.
there are some people distracting because in our country Zoom needs the VPN. So guys can answer in the chat section. I'm sorry. خب من خواهش میکنم که چالش تشخیصی اوتیت مدیا رو دوستان در قسمت چت برام بنویسن. Okay, I'm going to answer first. As a pediatrician, it's very difficult to examine the small children, especially the infants and children less than maybe 4 years. They always cry, the ears are always red. Sometimes it's full of wax or serum. You cannot see the tympanic membrane. Sometimes you have doubt whether this is normal red or acute otitis media red. And always parents say that my kids have a pain in the ear, his or her hands are always pointing the ears, you're not sure if they have pain or not. And sometimes kids are not verbal, sometimes they do not know how to express pain. These are the greatest challenges for me. And Mahdi, okay, Mahdi have this. No answer. This was some greeting. I don't see anything in chat section.
I don't see anything in the chat, so we'll see if we'll go ahead and keep going. But you got all the ones that usually I get. So the truth of the matter is, diagnosing ears is just not easy. There is an article in the Journal of Pediatrics in the United States years ago where they took a 50-ear video test, and they showed these same exact videos to a bunch of different practitioners. And one of their findings was the bottom 20% of finishing third-year pediatric residents had scores that were equivalent to beginning nurse practitioner students. So you would hope that when you graduate medical school and you have MD behind your name, you're at least as good as somebody who's starting nurse practitioner training. So what it showed is, 1 out of 5 residents, didn't seem to be any better at the end of residency than they probably were when they started. And then another article from the Journal of Pediatric Otorhinolaryngology, they found that ENT physicians scored better than pediatricians in assessing TMs on video. Pediatricians were a little better than family practitioners or general practitioners. And on average, residents had better scores with each subsequent year. So the average second year did better than the average intern, and the average third year did better than the average second year. So, but then when they looked at attendings, they couldn't find a correlation between their accuracy and their number of years in practice. So that basically that goes, so long as you have somebody who's double checking you, you tend to get better. But then when you graduate residency, you reach a plateau, and whatever level you're on in terms of skills, that's kind of where you stay for the rest of your career, unless you seek out additional training. So what we want to do with this lecture is to bring in the science to the whole business of deciding who's got ear infections and who doesn't. We probably all in every country know we're in the age of ever-increasing antibiotic resistance. Back in 2017, this was hitting the news. A lady from the state of Nevada here died of a superbug resistant to all 26 available antibiotics after traveling in Asia. And now, our news articles just keeps going up of the number of patients that are going to be dying from antibiotic-resistant organisms. And here in the United States, otitis media is the #1 reason why we write prescriptions for antibiotics in the pediatric population. And I'm not sure different countries are different, but in the United States, you cannot even get access to amoxicillin without a prescription from a doctor. So you have to go to a doctor. They have to find a bacterial infection or what they think is one, and then prescribe the antibiotic. So, questions like what's the positive predictive value of a red tympanic membrane, or what physical findings on exam are most predictive of acute otitis media, are some of the questions we'll try to answer in this lecture. So, what is our goal here? Our goal is pretty simple, okay? We want to prescribe antibiotics to all the children that are going to benefit from them. And we want to not prescribe antibiotics to children who won't. So the tough point here is how do we learn to differentiate between group #1 and group #2? So we're going to have 4 parts of this 2-hour lecture. And the first part is going to be building skills to make an accurate diagnosis. So if you ask, well, what can I do to maximize my skills? We're going to go over a thorough understanding of the anatomy and physiology of the middle ear space, and then talk about our basic differential diagnosis for middle ear pathology. We all have been taught that some middle ears are going to be normal, and some children are going to have acute otitis media. And for the purposes of this lecture, we're going to be very strict that when we talk about acute otitis media, we're talking about acute bacterial infection in the middle ear. So you can think of it as a middle ear abscess where you've got pus and organisms and white blood cells, and they're fighting against each other. And you get all the signs of inflammation. Okay. Now there's another diagnosis called otitis media with effusion. And so this refers to a middle ear effusion that's not an acute bacterial infection. And so you notice both of these, AOM and OME, and I'll abbreviate these a lot, but the O stands for otitis, the M stands for media. So the difference is, one's an acute bacterial infection and one means there's fluid there, but it's not an acute infection. So you could think of it like a pleural effusion. You can have a pleural effusion from a pneumonia where the bacteria and the white blood cells are accumulating in the pleural space, or you can have a transidative pleural effusion, like if you have heart failure or liver failure, where you've got fluid there, but there's no bacterial organisms and it's not an acute infection. And then fourthly, there's a diagnosis in the United States we call eustachian tube dysfunction. And if you're not clear on that, which most of our residents aren't when they start residency, hopefully by the end of the lecture today, you'll have that one down. Okay, and then there's others that are kind of beyond the scope of this lecture. Then we're going to talk about how to get the best possible view of the tympanic membrane. And I always encourage, often would give this lecture at the start of a clinic rotation, and I get in the habit of telling students and residents to describe what they see whenever they present the patient to a senior resident or attending. Because if you just tell, if you just give your conclusion, like I think it's, acute otitis media, or I think it's normal or it's OME, you probably get agreed with or disagreed with, but it doesn't make for much of a discussion. Whereas if you give the data you use and then you give your conclusion, you find the conversations are much more helpful. And then in the third part, we're going to learn how to correlate conclusions with tympanometry, which is a good way to add some objectivity into the whole process. So here's a good diagram of the middle ear space. And when we talk about middle ear, we're basically, the tympanic membrane is the dividing line between the external ear and the middle ear, and then the cochlea is the start of the inner ear. So you can see the tympanic membrane right here, the three little bones called the ossicles, how they fit together. And then here's a cochlea that goes to the eighth cranial nerve. And then here is the auditory or eustachian tube that ventilates the back of the pharynx into the middle ear space. Here's a nice drawing of the cross-section through the cochlea from our Netter Atlas, where you can see you've got your vestibular membrane, the tectorial membrane, the basilar membrane, the outer and the inner hair cells, and the spiral organochordae. And this is how the nerve impulses are generated that then travel through the eighth cranial nerve to the brain. Here's another cross-sectional view of the cochlea here, along with the semicircular canals. And here you can see how the three little bones fit together. So the ossicles, the malleus, incus, and the stapes. In this schemata, everything beige is bone, white is air, and blue is the endolymph. And here,
excuse me,
yeah.
I'm sorry, I'm interrupting you. Are you using your pointer?
Oh, sorry. Yes. Okay. I'm using it on screen.
We
Okay.
can see it.
Yes. Okay.
I'm
So
sorry.
here, thank you. Thank you for that. No, I would have messed up more. So
welcome.
here you can see this is the three little bones and how they fit together. The white is air, blue is endolymph, and beige is bone. And these are the three little bones. And I learned these in fourth grade as the hammer, the anvil, and the stirrup, also known as the malleus, the incus, and the stapes. And this is the way they fit together. So this is a medial view. So this is what you see, or this is the opposite of what you see when you look in through the otoscope. So on the medial view, you can see the malleus here. There's a process is part of a bone that sticks out. It's like you've got your coracoid process here on your scapula. So you can see the malleus has this process right here that's the shortest of the three. So some people call that the short process. And it's sticking out into the page, so laterally. So some people will call this the lateral process. Just know it's just one part of one bone. And so when we look through the otoscope right here, this is what we see, what you see right here corresponds to what you have right here. So this is the malleus that is the only bone that touches the tympanic membrane in health. And this is the short or lateral process that's sticking out towards us when we look through the otoscope. And then you've got your pars flaccida, the pars tensa, the rest here, your umbo, which is the center, and the cone of light. So now if everybody has a piece of scratch paper and a pencil or a pen, I'm going to kind of teach you how to draw the important features of the tympanic membrane to help you commit them to memory. So if everybody can get your writing utensils. And we're going to just draw a nice round circle as best you can and put a little dot in the middle of it, maybe just, to the left and down just a hair. And we're going to label that the umbo, which I believe means center in Latin. And we'll label that the right ear. Okay. Now from the umbo, we're going to draw a line up at a 45-degree angle and put a little nub at the top. And we're going to label that the malleus, and then the nub at the top is going to be the short process, or lateral process if you prefer. So since Sevil's the only one I can see, I'll go ahead and tell me when you're ready for the next step.
Yes, I'm drawing very hard.
Okay.
It's very, very interesting.
Okay, so you ready for the next step? Okay, so now
yes,
go back to the umbo, and we're going to draw an upside down ice cream cone. And that's going to be labeled the cone of light or light reflex. And that's actually the part of the tympanic membrane that's perpendicular to the otoscope when you look in through the otoscope. And then above the short process here, we're going to label that part the pars flaccida, which means flaccid or floppy part in Latin. So if you can commit these five parts to memory, it will go a long ways in helping you describe when you see something where to point to. And also to just, let you know that you are in fact seeing the tympanic membrane. I work in the teaching clinic, and there's been times in my career where I've seen even a senior resident sometime looking with the otoscope, and I can tell by the way they've got the angled. They're probably not even seeing the tympanic membrane. And if you look at the back wall of the ear canal, you're certainly going to say, well, gee, I don't see any landmarks. It looks opaque. It looks like it's infected. So anyway, I have to see either the umbo with the cone of light or the short process to really convince myself that I'm actually seeing the tympanic membrane. But this would be the five vocabulary, and I'm going to show you just some pictures of it. So here's one from a ear, nose, and throat textbook, where again you've got the umbo in the center, then you've got the cone of light going down here to the right, the malleus going up to the right, and the process at the top, with the pars flaccid above that. And so even though they didn't label it here, that's the other thing I forgot to say. From the umbo, in a right ear, everything that you're interested in is going to be to the right of the umbo, meaning the malleus and the cone of light. And in the left ear, the malleus would be going up to the left, and the cone of light would be going down to the left. So once you can see that, you know which ear you're looking at. And at any time you find the umbo, if you're in the right ear, you see the umbo, you always want to look more towards the face to actually see where the short process is. Okay, here's another view from a graphic designer. So again, the umbo in the center, the malleus going up here. At the top, you've got the short or lateral process sticking out, and the pars flaccid above that. You can see that the ink is through a translucent tympanic membrane in probably about 20% of people. But that doesn't normally touch the tympanic membrane unless it's really retracted. And then you see the cone of light again going down to the right. And then the rest of this, the pars flaccid is up here, and then the rest is the pars tensa. So this is the best diagram I've ever found in an ENT textbook that correlates what you see when you look through the otoscope with what's going on in the middle ear space. So we're going to go over each one of these 6 ears in detail. But first, I just want to give you the basic vocabulary. So anytime we're assessing an ear, we first want to look and make an assessment of position, and then we can look at color, translucency, and mobility, and then look for any special features. So position is the most important of all the things that we assess, and it's nice. It's more straightforward because we've only got 3 choices. The tympanic membrane can be in a neutral position, which is what you see right here. Or it can be sucked back into the retracted position, which is what they're illustrating here with the black dots. So if you blew in with pressure here, you can move it back to the retracted position where the black dots are, or it can be moved out the other way, and this is what we call the bulging position. Now, some old pediatricians in the United States would sometimes say a tympanic room like full. The new guidelines all talk about bulging, but if you just ate lunch or dinner, if your tummy is full, it's going to be bulging out a little bit. So, but the new guidelines all use the term bulging. Okay. In terms of color, it's not so straightforward. We all learn when we're medical students that a normal tympanic membrane should be kind of pearly gray or tan looking, and we think of an acutely infected one as being red. But not all red TMs look the same. You can have distinct erythema versus just very slight erythema. It can be very focal erythema in one place, or it can be diffuse all over. Unfortunately, sometimes TMs look, pink, yellow, white, amber, blue. And to me, it's a lot of times hard to just choose a single color. I can point to this down at the bottom. If you can see, that's green, yellow, blue, maroon, orange, navy blue. If you look at a tympanic membrane and you say, well, it's kind of pinkish, but there's a little red there, and it's kind of yellowish right there. So the only way color really helps us is if you see the perfectly normal pearly gray color. That's enough to basically say you don't have acute otitis media and you don't need to give antibiotics. You can't have acute otitis media with a perfectly normal pearly gray color. Now, having an abnormal color doesn't really tell us anything. So an abnormal color doesn't mean you need antibiotics, but a normal color means you don't. Okay. Now, another aspect of the tympanic membrane is it should be translucent. Okay. Now, translucent is not the same thing as transparent. So I don't know if these are going to show up good in real life, but this is a water bottle that's transparent. You know, you can see my face through it. This is a water bottle that's translucent. You can see I've got some water there, but you know, you can't see my nose, okay? So the tympanic membrane is never going to be transparent, but it should be somewhat translucent. You should be able to see, is there, you know, get an idea if there's some fluid on the other side. And then the opposite of that would be opaque. And some people use the terms cloudy or dull. But if I fill this with milk, you know, all you could see is, okay, I see white stuff behind it, but I can't see beyond that. So that translucent is a normal, opaque is the abnormal. Okay, and then mobility. Some people are rated as 4+ being the best, a 3+, 2+, 1+ are absent, and that's when you get an insufflator and plug it into the otoscope. But not only is there mobility, I always like to, you know, ask myself, am I seeing brisk mobility or dampened and impaired mobility? I don't know if this is going to show up well, but if I'm going to blow on this napkin here, and if you look at the edges, it will flutter, you know, when you have something thin with air on both sides, you know, it will flutter back and forth really quickly. Whereas if you got, you know, fluid in the middle airspace, you know, you can get it to move, but it'll be, you know, a dampened shock absorber type movement, like if you're, you know, step on a bumper of a new car, you know, it'll be, you know, but an old car maybe like that. So I'm asking myself, when I see mobility, does it look nice, crisp, brisk mobility, or is it look like, you know, you got fluid, you know, honey on the other side, and it's just, you know, you get it to move slowly. Okay. And then special features that we can look for. So we can see air fluid levels in an upright patient. And if you have a lot of fluid and the patient's not upright, you may see air bubbles, okay? You can see increased vascularity, like part of the TM, like you see right here. Tympanosclerosis is kind of a whitish scar tissue that can form in a TM where it's been inflamed or injured in the past. And then retraction pockets aren't that common, at least in this country, but sometimes you see them, and you'll know that if you're insufflating and all of a sudden it looks like the TM is not moving very much, but you see a little pocket that's hypermobile. If you see that, that's a retraction pocket you just found, and we would send those to our ear, nose, and throat colleagues. And then a cholesteatoma is a benign tumor that's in the middle ear space. It's benign in the sense that it's not cancer. It's you know, there's no malignancy involved, but it's not really benign in the sense that it's you know, it can really give a patient a good conductive hearing loss. So these are not common at this stage in the United States, but one of my ear, nose, and throat friends that did some mission work in some countries in South America, he said they were pretty common down there as a sequelae when you've got you know, otitis media that has not been treated with antibiotics. They, you know, then can, you know, get these tumors, you know, tumors growing from the injuries, and then give somebody a conductive hearing loss. Okay, so this is a famous cartoonist in the United States, and so this is the world's first microscope right here, and here's a caveman sitting on the top, and he says, yep, it's a mammoth. So before we get out our otoscopes, I just wanted to share with you a quote from one of the national leaders here that he came to Arizona and gave us a weekend seminar on how to improve our diagnostic accuracy of acute otitis media. So I always like to give him credit for that. And one of the things that he pointed out back in 2004 that's made its way into the AP guidelines, it's really the position of the tympanic membrane is the key to the differential diagnosis. So when the position is bulging, you know, you've got criteria for acute otitis media, and when it's neutral or retracted, you don't. And so the latest guidelines we have from the American Academy of Pediatrics are from this 2013 guideline, which is very well done. And they basically said, you know, to diagnose acute otitis media, children need to have one of three things, and they need to relate to the physical exam finding of bulging. Okay. So first of all, they said when you got moderate to severe bulging of the tympanic membrane, okay, that's acute otitis media. And here what you see is severe bulging, and this is more mild to moderate here. Then secondly, they said if you got new onset of otorrhea, not due to acute otitis externa. So if you were all sitting around the table with me, I'd ask you to shout out, well, you know, where are they getting this? You know, how does new onset of otorrhea, you know, I mean, well, we know what that is, but how do you know if it's due to otitis externa or not? So I'll just, without the audience participation, I'll just give you the answer. But basically, if you got it, we have in Arizona here, we have a lot of swimmer's ear, which is otitis externa in older kids in the summer. And in those kids, it's basically, otitis externa is basically a cellulitis of the external auditory canal. So if you do this to somebody with otitis externa, it really hurts, and they'll slap you, they'll scream or do something, but it's kind of like slapping somebody with a bad sunburn. It really hurts. Whereas if you have a little kid that had an acute otitis media that perforated, you do this to them, and they're usually, if you can touch their ear and they don't cry, if you do this, they usually don't cry either. Okay. So how does this relate to bulging? Basically, if you have, no bulging to mild bulging to moderate bulging to severe bulging, at some point you can't bulge anymore. And then the tympanic membrane will perforate, and that's all of a sudden you have acute onset of otorrhea from a kid that had a very painful ear, and then okay, you did have severe bulging. Okay, and then you say, okay, well, we've talked about moderate bulging, severe bulging, super severe bulging that perforated. Well, what about mild bulging? Well, the guideline said if you got mild bulging of the tympanic membrane, you need to have something else in addition to it to diagnose acute otitis media. So the best something else is when you got recent onset of ear pain within the last 48 hours. So if a kid can talk and they come in and a kid's saying, "Mommy, my ear hurts, it hurts really bad," and you see that you got mild bulging in there, they're saying, like such as you have right here, oh, sorry, what you have right here, more mild bulging where it's not affecting the lower part of the tympanic membrane yet. They're saying, okay, well, you can diagnose otitis media and prescribe antibiotics without waiting for it to become moderate or severe or to perforate. Okay. But the guidelines also go on to say that we should not be diagnosing otitis media in children if they don't have a middle ear effusion. And we should be doing something objective to determine whether they do have a middle ear effusion. So one objective thing, we can use plug the insufflator into the otoscope and see if we can get the TM to move and if we see fluid there. Or we can use a tympanogram. So this is one of the older Welch Allen ones. We have newer ones that look different in our clinic, but basically if you do a tympanogram and you get a type B, that doesn't mean for sure you got otitis, but it does, does likely mean that you have a lot of fluid behind the tympanic membrane interfering with the compliance. Whereas a type A or type C tympanogram means you don't have a lot of fluid back there, and therefore shouldn't be diagnosing otitis. So a few years ago, once we got our new tympanogram, we told the residents we don't want anybody diagnosing acute otitis media anymore without doing a tympanogram and getting a type B reading, and reduced our use of antibiotics that way. So now that we've talked about position being the most important thing, whether it's neutral, retractor, or bulging, we have to ask ourselves, well, how are we going to determine that? Okay. And why is it that way? Okay. And basically, if you were to sum it up in one word from physics, what determines the tympanic membrane position is going to be what is the pressure, the air pressure behind the tympanic membrane, how does that compare to the atmospheric air pressure in the canal? So if your middle ear pressure back here is the same as the external auditory canal out here, by definition, you're going to be in neutral position. And that even if there's fluid back there, the air pressure is the same, you're going to be in neutral position. But if your middle ear pressure back here that's below atmospheric, then it's going to be sucked back into the retracted position. And if your pressure back here is more than atmospheric, it's going to be pushed out to the bulging position. Okay. And this is a fun little YouTube video that kind of illustrates how, the pressure changes, how strong they can be in moving things. So hopefully give me a thumbs up, Sevil, if you can hear the video okay. And I edited the video to make it not so long, but I'm going to stop it halfway through and see if...
So what we have here is a gigantic barrel. Right now it's filled with water that we've been boiling for quite a while. And so as the water's boiling, it's evaporating and it's pushing the air out of the barrel. And so now it's just really filled with mostly steam. So Nick is going to cap the barrel at the end and lock all the steam inside. Then we're going to cool it down and we're going to see what happens to the barrel and the water inside. Anybody have any predictions as to what might...
Okay, so anybody want to guess what's going to happen to that barrel when they put it on the ice?
Is it going to be retracted or exploded?
Okay. One of the two. So let's see what happens.
So every square inch, like the tip of your thumb, of your body right now has about 14.7 pounds of atmospheric pressure. But when there's no air inside of the barrel here, that atmospheric pressure is enough to crush the barrel, and it did.
Very surprising, because it happened all of a sudden. It was like, pah! I did not expect it to just collapse inside of itself. That is not one that crossed my mind at all.
Okay.
Amazing.
Yeah. So you can imagine if we take atmospheric pressure for granted all the time, but you can imagine if it's enough to crush a steel barrel like that, you think of what even small changes in pressure can do to a flimsy little tympanic membrane. And so for anybody out in the audience that didn't get the engineering there, what they did is, when they started the barrel with it uncapped, the barrel is full mostly of nitrogen and oxygen molecules, just like we have in our air all the time. But then when they put some water in there and they boiled the water, so that means all the water became steam, and then the steam pushed out all the oxygen, or most of the oxygen and the nitrogen. Then they capped the barrel when it was still hot, so that you have all the water vapor inside. And then when they cooled it, the water vapor became back to water again. And so you have all these oxygen and nitrogen molecules from the outside pressing on the barrel, and you don't have the same number of oxygen and nitrogen molecules on the inside pressing against the barrel. So the oxygen and nitrogen molecules just crush the barrel from the atmospheric pressure. So now we're going to go to the, figure out how we're going to assess the tympanic membrane position, because we know it changes with the pressure. So at this point, I'd like to ask you, is the water level in this photo going to be 6 to 12 inches above the ground, 2 to 3 feet above the ground, or greater than 6 feet above the ground right here? And again, this is where we would use the audience response technology, but I'll just have to kind of walk you through it without it. So anyway, if we could do this, we'll do it. So I would have people vote, and usually, some people would vote for each of these three. And the actual real answer was, I didn't give it to you. You can't really tell without any fixed landmark. What you really need to do is have something, a pole or something that you can put in there to really determine. Okay. And there was one in the picture, but I haven't showed it to you yet. Okay. So I think now you can see that the right answer was 2 to 3 feet above the ground, assuming these guys are standing on a grassy lawn or on a sidewalk. Now, if they're standing on top of a building, it's obviously over 6 feet. And if they're standing in an irrigation ditch, it could just be 6 inches above the ground. But this is a flood that took place in the United States years ago, and so anyway, assuming these guys are on level ground, it's 2 to 3 feet above the ground where they are. So now we have to, decide with this tympanic membrane, how are we going to decide if it's, 1 or 2 millimeters pushed back into the middle ear space, or 1 or 2 millimeters pushed out in the bulging position? Okay. What are we going to use as our fixed landmark? So here's another picture here. And usually pause a little bit to let people think about it. But, usually people say, well, the only thing that touches the tympanic membrane is the malleus right here. And so if we, there's a form we have in our anatomy class where they say form fits function. So the form of everything in the body has to do with the function that it has. So now, we have a lot of people in the United States will have a trampoline in their backyard. And so we're going to think of the tympanic membrane as a trampoline. Okay. So if somebody's jumping on a trampoline and you want to move a lot, you would sit pretty close to the center, so you can bounce up and down as they're jumping. And if you don't want to move very much, you would sit at the edge. Okay. Now we also have seesaws on our playgrounds here in the United States. And so if you're on a seesaw and you don't want to move much, you sit in the center. And if you want to get movement, you sit on the edges. So think of the malleus here as a seesaw and the tympanic membrane as a trampoline. So you can see where the malleus ends right here. So the edge of the seesaw and the center of the trampoline are right here in the center. So this is what's going to get the greatest amplitude of movement. And then the least amplitude of movement is going to be over here by the edge, okay, which is the fulcrum of the malleus and the end of the tympanic membrane. Okay. So now we can ask ourselves which part of the tympanic membrane is going to be the most sensitive to pressure changes. So you've got the pars tensa right here, where the tympanic membrane is pulled really tight. And you've got the pars flaccida up here, where it's kind of floppy and loose, okay? So if the middle ear space is filling up with pus, which part do you think is going to be bulging first? Will you see the bulging where it's pulled really tight, tensely, or will you see the bulging where it's kind of flaccid and floppy?
Of course, in the flaccid part.
Okay, so very good. So this is the top part of the tympanic membrane is the first to bulge. And Mother Nature was good to us pediatricians as she put the pars flaccida right next to the short or lateral process of the malleus, okay? So when we're trying to assess position, the only place we want to be looking on the tympanic membrane is up here, okay? Now, I had a pediatrician when I was a third-year medical student tell me that, to look up here, but he didn't really explain to me why, okay? Then I went through pediatric residency, and nobody, again, really talked to me about the importance of looking up here until that Dr. Pikikaro came to town, and he he explained to everybody that, to assess bulging, you really have to compare the position of the short process of the malleus to the pars flaccida. So if you're looking for air bubbles, you can look all over, or what color it is. But when you're trying to assess position, don't look down here. There's no fixed landmark that you can use as a reference, okay? The only fixed landmark you got is the short process, and it's right next to the pars flaccida. So when you're assessing bulging, you can find the elbow, but then go up and anterior to the face and look up here to make try to make an objective call. Okay, so now we're going to go over each one of these diagrams from the ENT textbook, and I've added some still shots here so you can kind of see what they look through the otoscope. And I'm going to kind of make it into a story. So we're going to start with a 18-month-old well check. They come in here, and you as the medical student or resident are looking at them, and you look in the ear, and you see a malleus at a nice 45-degree position. The short process is sticking out like normal. The cone of light is going on down here. So here you can see the still shot. There's your normal short process right here, or right here. The cone of light's going down to the right. So these are all right tympanic membranes. And in this schemata, gray is air. So you see you've got air on both sides of it. White is bone. So here's the 3 little bones there. And then you can see when you blow in with positive pressure, you can move it back to the retracted position. If you sucked out, you can move it out to the bulging position. And you got normal mobility. So you tell the mom, okay, your kid's ears look fine. And she says, well, I wasn't really worried about him in the first place. He's got normal speech and he's not complaining. I'm just here to get my vaccines. And so she gets her vaccines and she goes. But we're going to say this was today's Thursday. So we're going to say this was Thursday that you saw the kid. And when he was in the waiting room, there's another little kid there with, RSV infection, and he's got, lots of purulent secretions or clear nasal discharge coming out of his nose, and they play with the same instrument. And so this kid just got inoculated with rhinovirus or RSV. And if he goes home from the clinic, and a few days later, he starts to have clear rhinorrhea. And then a couple of days after that, he starts pulling on his ears. So mom brings him in to see you the next week. And she says, well, you told me his ears were perfectly normal last week, but now he's pulling on his ear, and I want to know if he's got an ear infection. So you say, okay, well, this is good. I remember what they looked like last week. And you go in and you look through the otoscope, and instead of seeing this, you now see this. Okay, so we'll go back. So this is today, this is next week. And so what you see here, the malleus is now more horizontal. And you can see by looking through the, in this section right here, you can see how the tympanic membrane has been pulled back into the retracted position. So if you blow on with positive pressure, maybe you can move it back just a hair, but not very much because it's already retracted. Whereas you could suck it out to the bulging position just the same. And you've got, gray means air. So you've got air on both sides of the tympanic membrane. And as you look at it, you can see the malleus even more, and the short process is sticking out even more than it normally does. So this one's pretty retracted. This one probably even more. And then this one is so retracted, and it's been retracted for a while, that you can actually see now the incus is touching the tympanic membrane right here. And you can see it's been sucked back in so much that it's actually touching the medial wall. So this part of the TM, I think he drew it a little big here, but this part of the TM is actually touching this part right here, which is what you see right here. So this one has been retracted for a long time. And the other thing that's good to understand about a retracted tympanic membrane is pretend this is, if you can see my fingers here, this is going to be the short process sticking out, and this is going to be the malleus. So the whole tympanic membrane is kind of like this. So as the tympanic membrane gets retracted, the malleus looks like it's getting shorter and more horizontal. So again, this would be neutral position at a 45-degree angle. This would get retracted, so it looks more horizontal and it looks like it's gotten shorter. Okay, so what would the diagnosis for this ear be? Okay, this is now, negative. You can say this ear has negative middle ear pressure. The position is retracted. And the diagnosis would be eustachian tube dysfunction. And so, this eustachian tube is what normally ventilates the middle ear to the external world. And well, why do we have eustachian tube dysfunction? Well, what lines the eustachian tube? Okay, it's the same respiratory mucosa that you have on your nasal septum and your turbinates. And what happens when you get a viral infection? Okay, respiratory mucosa swells up, and that's why you get your stuffy nose when you have a cold. And so the eustachian tube is a pretty thin tube to begin with, and especially the isthmus where it just enters the middle ear space. So if you have a thin tube that all of a sudden gets swollen, and then it gets swollen, at some point it gets swollen shut. Now, the moment it gets swollen shut, the pressure is still the same here, but you no longer have free communication between the air molecules back here and the air molecules in the back of the throat. So a swollen shut eustachian tube then leads to a fixed pocket of air, and then routine physiology takes over. So what happens when you have a fixed pocket of air anywhere in the body? What would be some examples? And again, I can't,
the air would be absorbed, and then you would have negative pressure, like sinusitis. What happens in sinusitis when the entrance of the sinus is obstructed, like in eustachian tube, I think.
Yeah, exactly. And so other examples would be, for example, a pneumothorax is a fixed pocket of air. So if a baby's born with a small pneumothorax, do you stick a chest tube in it right away? Yeah. No. Okay, the neonatologist is going to say, okay, well, it's only a 10% pneumothorax. Let's just leave it alone, and the air will absorb on its own. Okay. We can have a pneumoperitoneum after a surgery, surgeons do a laparotomy or laparoscopy. They can't get all the air out. They get most of the air out, but some of the air is in there. And so how do you get rid of a pneumoperitoneum? If it's just from air left over after surgery, you just wait. Now, if it's from perforation, then obviously that's a big deal. But anyway, a small pneumothorax, a small amount of air left in the peritoneum, pneumomediastinum, okay, where you have crepitus in the neck, okay, your tissue pressures are very slightly negative, and so with time, your tissues will absorb the air. The oxygen molecules can be used up. The nitrogen molecules can kind of diffuse. So after a eustachian tube's been swollen shut for a period of time, you then have less air molecules behind the tympanic membrane than you do out here in the atmosphere. And so less air molecules means less air pressure. And so the TM gets sucked back into the retracted position. And, here in Arizona, we have a pretty big elevation difference. I'm in Phoenix, which is about 1,000 feet above sea level. But if you drive 2 or 3 hours to the north, it gets up to, 7,000 feet, which would be, I guess, 1.5 kilometers if you use kilometers. When we drive on Interstate 17 going from Phoenix to Flagstaff, you feel some discomfort in your ears. I usually ask the residents, do you feel like a discomfort more when you're going up, in a plane or on a highway, or when you're going down? And most people, their memory of having ear discomfort is more when you're going down. And that makes perfect sense. And for, everybody who's flown in an airplane, when you're going up in an airplane, that makes this air a net positive, and it will tend to force the eustachian tube open. And sometimes if you'll pay attention, you can actually, as you're going up in a plane, you can hear a bloop, bloop, bloop. And, if you have a cold, and that's air escaping through your eustachian tube out to the middle airspace, out to the atmosphere. And then you'll get to a cruising altitude and you'll be fine for a while. And then about 40 minutes before you're going to reach your destination, the plane starts to go down. The captain hasn't said anything about putting your seatbelt on yet, but you start to feel a pressure behind your ear if your eustachian tube's not open. And you can try to yawn or chew gum or do something to open your eustachian tube. But if you can't, as you're going down in elevation, it just that air pressure is building up. And I've flown a couple of times where I've had a cold and it just seems like somebody's got a little needle and they're just jabbing in my ear for the last half hour of the flight. And it can be really terrible ear pain, okay? Because the atmosphere is then pushing your tympanic membrane back into the retracted position. And it's the stretch receptors that cause the pain, both in acute otitis media as well as in eustachian tube dysfunction. And so it can certainly hurt. And that would be for the mom of this 18-month-old who's now got a cold and eustachian tube dysfunction. That's an analogy I'll use to kind of explain, okay, that's why your kid is pulling on their ear and they're saying it hurts because they've got eustachian tube dysfunction. Okay, now what's the natural history for eustachian tube dysfunction? Well, it's the same as the natural history for your respiratory virus. Okay, your nasal turbinates don't stay swollen forever. And after a few days, the inflammation starts to go down. And as soon as the eustachian tube can open, just, even for a split second, by yawning or something, air can rush in there, the pressure can equalize, and it snaps back to the, neutral position that it was. And so anytime you've been traveling and you do manage to yawn or do something and you feel your ear pops, that's what that ear pop is. It's going from the retracted position to the neutral position. Okay. Now, so the natural history of eustachian tube dysfunction, most of the time it resolves on its own, but not 100% of the time. So sometimes if you have eustachian tube dysfunction that goes on for a long enough time, you can get the buildup of fluid back there. And remember this, respiratory mucosa is lined by goblet cells. The goblet cells secrete mucus. And there's also cilia, and the cilia should be moving that mucus on. So it's produced here and it will move it out through the eustachian tube, the back of the throat, and then get swallowed. But if your eustachian tube is plugged up, you can get the buildup of fluid. And that will lead to what we call otitis media with effusion. And that's when in an upright patient, you'll see an air fluid level. So this is a pretty small effusion that's kind of small to moderate. And sometimes the effusion is clear fluid, sometimes it can be cloudy fluid. But either one of these ears will classify as otitis media with effusion. And the AAP guidelines we have are pretty clear that we would not treat otitis media with effusion with antibiotics because most of the time otitis media with effusion will resolve on its own if you just give it time and be patient. So none of these ears would warrant antibiotics at this point. And most of them will resolve, but let's say they don't resolve. Okay, sometimes you get the buildup of effusion to the point where the whole middle ear space is now filled with fluid. And you can see sometimes that by seeing air bubbles. So you can see an air bubble right there, right there, right there. These would be ones that we would sometimes put the diagnostic term serous otitis media on, which is just a kind of a subset of OME. But anytime you're seeing an air bubble on the other side of the tympanic membrane, you've got a large effusion there because you don't see air bubbles in the middle of air, you see air bubbles underwater. So again, this is a large middle ear effusion. It can be clear fluid, it can be cloudy fluid, but there's not any bulging yet. What they're showing here with the arrows is you don't get good movement in either direction because you don't have enough air back here to create a gradient. So you can't really move it back to the retracted position. You can't really pull it out to the bulging position. Okay, so this is still classified as otitis media with a large effusion, but not yet acute otitis media. And this can resolve on its own, but if it doesn't, and all of a sudden you have a little pneumococcal bacteria coming back here, Moraxella, H-flu, one of the pathogenic bacteria, these guys can double their number every 45 minutes or so. And so I'll always ask the resident, would you rather have $100,000 or a penny that doubles itself every day for the month of May? And if you think about it, a penny that doubles itself, 31 times by the end of by the 31st day, you've got over $8 million coming to you. So one bacteria that can double itself every 45 minutes in 24 hours, you've got millions of bacteria, okay? So what are you going to do if you're the captain of your body's immune system and you get a report that there's now millions of bacteria floating around in this fluid behind the middle ear space? You're not going to be okay with that. You're going to say, well, we need to send in the troops. So we'll send in the neutrophils and the macrophages and other white blood cells. And now you got white blood cells going in search of bacteria in the middle ear space fluid. And what's that going to quickly become? Okay, whatever type of fluid it is will quickly become pus. Okay, and so that's when you start to get bulging at the pars flaccida. So these are pictures that I took myself, and you can see this one is kind of an early otitis media where you've got bulging up here at the top, but the lower half of the tympanic membrane still looks normal. And now you can see where it's gotten to be moderate to severe bulging, and you're seeing, you don't see that clear cone of light down here. And you can't see that short process sticking out at you anymore, even though you can see that this is a malleus. And then when you get to severe bulging, instead of seeing what you see there with severe bulging is you see a crease. So I'll try to emphasize that, right here with my trusty napkin. If this is a short process right here, as it bulges out, it kind of bulges here and then here. And so you're no longer seeing the malleus, but what you're seeing is a crease. And it doesn't show up really good, I guess, over the camera, but you're seeing a crease, and the malleus is buried at the bottom of the crease. So you can see that, that's a short process right there, and there it's kind of bulging out around it. That would be a short process, is bulging out around it. But you've got a pus in the middle ear space, and it's causing the tympanic membrane to bulge out. And this is what we would call acute otitis media. And here's, I think I got some, in terms of how you describe it, some people say it kind of looks like a buttock crease with the buttock turned at a 45-degree angle. Some people say it looks like a pars cervix, again, turned, with the pars part at a 45-degree angle. The guidelines a lot of times will describe it as donut shaped or even like a seashell. But these are still shots of what it looks like when you have a severely bulging tympanic membrane. So you can see how all of these look like the pars cervix or the donut. So these ears are ones that this is what we're looking for when we really decide, does this kid need antibiotics or not? And all of these ears, I would definitely, say should be treated. Okay. And then if they continue to bulge and antibiotics in the immune system don't get there in time, that's how you're going to get the spontaneous perforation. So this would be a pretty small one. This one's, moderate to large, and then, this one would be really large. And so the moment that happens, the purulent fluid leaks into the ear canal. The pain usually goes away within minutes. And that Dr. Pickicro is referring to, he brought some mannequins and taught us how to do tympanocentesis, which is not done here in the United States very often, certainly not by general pediatricians. But after his lecture, I did learn how to do a few. And the times I tried it out was when I was in the emergency department. And if a teenager came in that I could trust to hold still, and they were like almost in tears because it was hurting so bad, I found that by doing a tympanocentesis, with a lumbar puncture needle through the otoscope, their pain would go away within 5 minutes, and got a culture to grow out. So this is what can happen anytime you have an acute otitis media. Okay, so now we'll move on to the second part, and this is going to be brief, but just how do we get a good exam? Okay, so I thought I would walk you through my algorithm. Anytime I approach an ear exam, I get on my otoscope, and I know I'm going to get to 1 of 3 endpoints. It could be that I see the tympanic membranes very well without struggling too much. It could be I get in there and the kid has too much cerumen, and I realize I'm not going to be able to get a good look without cleaning it out. And kids don't like it when you clean out their cerumen. Or it could be I haven't even tried yet, and the kid gets spooked or starts fighting. Okay, so whenever I run up against one of these obstacles, I don't get aggressive right away, but I stop and I ask myself, what's my pre-exam index of suspicion that he's got acute otitis media? And then how old are they, and how big are they, and can I get their mother to hold them still? Okay, so if my pre-exam index of suspicion is low, meaning they don't have any ear pain, then and they're old enough to talk, well, then I know, okay, this kid's not likely to have an acute otitis media. It's not worth it to force an exam on them. And I just explained to the parents that, I can't see your kids here today. Do you have any concerns? Mom says no, and then I'm done. And I'll document in my note, unable to see the tympanic membrane. Okay. But what if the pre-exam index of suspicion for otitis media is really high? If the child is 7 years old and they're autistic and they can't control their behavior, but they're really obviously in pain, well then I might say, in that case I might consider prescribing antibiotics, because I'm not going to try to hold a 7-year-old down, and it does seem like they've got otitis. But let's say the patient I've got a patient that is over 2 years old and they're verbal and they're not complaining of ear pain. Okay, in that case, I think I went through that earlier. I'd just tell the mom, I can't see your kids here today, and we'll try to do the exam there. Same thing if they're less than 2 years old, but they don't have a fever, they look well, I'm not going to get in there and aggressively clean the ear canal. But if they're less than 2 years old, in which case I can get the mom to hold them still, and they've either got a fever and I'm looking for a source of the fever, or mom thinks they have ear pain, then I think it's really worth it to be aggressive with an exam and hold them down and clean out the cerumen. So when I in the rare cases that that applies to, I think this is what I found is the best position that works. And so you get the little kid and you have mom squeeze the kid's pelvis in her axilla. Okay. And you keep his feet away from the wall. So at this point, your abduct, your flexors and extensors in your thighs are the strongest muscles. But by putting him on his side, he can't really use those. The only thing he can use against the table is his abductors, which are pretty weak. So if mom is resting all of her weight and the kid's in this position, she's pretty much taken out the lower part of his body, his ability to move much. Okay. Now she's still got her 2 hands free to grab his shoulders and his hands. So in this hold, he's pretty still below the neck. And the only thing I, as a physician, have to do is keep the head still. So at this point, I'm going to come in, and that just goes through that. So I'm going to push his head into the soft table with one of my hands. And then I've got the other one free to use my little curette here. And so if mom can hold him still from the neck down, I can hold him here. And in this position, he doesn't have much rotary movement. When you're upright, you've got about 90 degrees each way. But when you side bend, you don't have that much. And so me pushing his head into the table like this, even if he's maximally fighting, if he's less than 2, I can probably get the kid still enough where I can reach in there with a curette. And I can also use my insufflator there as in one hand as I look through the otoscope with the other. So in our exam rooms, we have these white curette and the blue ones. I don't know if these are commercially available where you all are, but I found that the key is learning how to hook and pull the cerumen out and not scraping. So when I was an early intern and cleaning out my first few years, I used these little blue ones because I thought they were smaller, but the tips are pretty sharp, and I made a fair number of ear canals bleed. And mothers didn't like that, so I decided, okay, I need to get more gentle. So I switched to the white tips, and I got more gentle with my techniques. So I'll only try to clean out a cerumen if mom can hold them still. But right now I've got to the point where I can get in there, and probably 80% of the time I can get the cerumen out enough where I can see the tympanic membrane. And it's very rare that I would make an ear bleed anymore. But anytime a physician makes an ear bleed, be sure to tell the mom right away. Here in the United States, when I used to work in the emergency department a lot, every now and then a kid would come in and the mom would say, I went to the pediatrician today, he cleaned out the wax out of my kid's ears, and then I got home and some blood came out on the pillow, and I want to know if his ears are okay. I've never seen a case of a pediatrician actually causing a traumatic perforation. I've seen people do it themselves a lot with the cotton Q-tips, but not a physician. But anyway, if you explain to the mom right away that the way I kind of say is the skin here in the ear canal is paper thin, and sometimes you just barely touch it and it'll start bleeding. It will heal like any other scratch on the skin, and that usually gets them to calm down. But what I try to do is just kind of come in behind it and then get it and very, very gently pull it towards me without doing a hard scraping motion. which is what's going to cause the bleeding. And then you can come in at different angles and try to get it out that way. Okay. So at this point, yeah, I don't know if you want to take a break or if you want me to keep going. This is kind of halfway through. So sometimes when I'm giving this in person, I give the residents a break.
We can take a break for 5 minutes if it's okay with you.
Sure.
Can
Okay. Yeah.
drink some water. Okay, so we'll get back 5 minutes later. Thank you. And actually, this was very amazing. None of these have I done. I've never removed the serum. Actually, in my country, it's not that common for a pediatrician to remove the serum. We always refer to the ENT colleagues. We never ever do the nematoscopic otoscopy. So these are very unique for me. And the next morning, I will try to, buy some stuff from my hospital and make them work. Thank you so much. And I'm going to drink some water because it was too much for me.
Okay. Yeah. I found that the cleaning the cerumen is a skill that either residents learn how to do it early in the residency or they never learn it. And the best place that we had here where I learned to do it is we have our public hospital emergency department has a lot of, mothers bringing their kids late at night with the fevers. That group doesn't, a lot of times doesn't have insurance and they can't see the general pediatrician, but they can always go into the emergency department. And so at night, the kid has a high fever. The rest of your exam is normal except for maybe a runny nose, and you really want to know, is it fever without source or is it fever due to an ear infection? So and so because their kids have a fever, the moms are usually pretty agreeable to the doctor cleaning out the ear canal to see if it's an ear infection. And I found it's, I definitely like knowing and getting a good exam rather than just guessing. But some of the attendings I had in the emergency department, some of them would clean out ears and some of them would just see the slightest red and prescribe antibiotics. So that's also one of the reasons why I developed this as a subject of interest for me, because I didn't like the idea of just guessing when there's objective things that we could do to decide. And I've also, I work as a hospitalist here too, and sometimes, a lot of kids, get misdiagnosed as having an ear infection and they get an antibiotic for it when they really have something more serious. And so it's, it's very common when we see a kid with either Kawasaki's or a serious bacterial infection that, somebody's diagnosed them with an ear infection that they didn't in fact have. One of the saddest case I had, there's a girl who came in with stage 4 neuroblastoma who didn't make it, and her parents had taken her to, 3 or 4 doctors in the preceding 2 weeks, and they all said she had ear infections when, her problem was, why she wasn't wanting to eat. It was that her abdomen was full of tumor.
So sad. I'm so sorry to hear that. Okay, so I think we can take a break after a few minutes. We'll get back.
So I'll turn my camera off and you just shout out. I'll leave the sound on, so you shout out whenever you're ready for me to.
Okay, sure. Okay, can we start?
Sure. Okay.
In the meantime, I talked to Dr. Tavasoli. He was on a round and he said, sorry, he cannot be with us. Maybe at the end of the session. So we can start, I think.
Okay. Yeah, he texted me too. Yeah, he's got clinical duties today. So, okay. So now we're going to talk about tympanometry. And this comes from, I'll just give you a brief outline from another talk, but one of the things that makes otitis media confusing is there's, certain kind of Bibles of evidence-based medicine that we use, and they don't necessarily agree with each other. So are you all familiar with the Cochrane Library?
Yeah.
Okay. So this comes out of the Netherlands. And so a 2015 meta-analysis of antibiotics versus placebo. They did a pretty extensive literature search from 1966 to 2015. They looked for high quality prospective studies of antibiotics against placebo in high income countries. And they chose studies that they felt had a low risk of bias. And they found 13 randomized controlled trials to include in their study that comprised over 3,401 children with nearly 4,000 episodes of acute otitis media. And their primary outcomes were ear pain at various time points and adverse events related to antibiotics. And the secondary outcomes included abnormal tympanometry, TM perforations, contralateral episodes, recurrences, serious complications, and long-term side effects. And their findings were by 24 hours, they said 60% of children had recovered, regardless of whether they were getting antibiotic or placebo. They did find some benefits from pain reduction, not at 24 hours, but at 2 to 3 days. But the numbers needed to treat the benefit weren't very good. You had to treat 20 children with antibiotics to have one child have less pain at 2 to 3 days. And even after 10 days of antibiotic treatment, you had to treat 7 children to get one child to have an improvement in their pain. It improved tympanometry slightly, but you needed to treat 11 children with antibiotics for one to benefit. You had to treat 30 to 3 to reduce perforation. And then there is some harm in getting antibiotics compared to placebo. So if you gave, 1 out of 14 kids that got antibiotics, had a harm from it compared to placebo. So their conclusions of the Cochrane Library is in high-income countries, most cases of acute otitis media are going to spontaneously remit without complications. And we found that antibiotics were not very useful for most children with acute otitis media. They said severe complications were rare and did not differ between children treated with antibiotics and those treated with placebo. So, and they said that there was enough research and the quality was high enough that they didn't think further research was likely to change these findings. So if we're pediatricians and we like the idea to feel like we're Superman by protecting innocent children from bacterial invaders by writing for antibiotics, this is pretty deflating. It seems like we're giving out all these antibiotics and we're not really benefiting the kids very much. So the Cochrane Library is one of the kind of the go-to evidence-based resources we use in the United States. And can you imagine being a pediatrician, giving this information to the mothers, hey mom, there's a 1 in 16 chance that this antibiotic is going to work better than placebo in reducing your daughter's ear pain in the next 7 days. Does anybody give this information out to parents? I've never done it, and because you don't want this look from the mom is like, come on, or is that the best you can do for me? Okay. So another resource we use, and I don't know, this is subscription only, but our hospital pays for it, is Up to Date. Are you familiar with this, Sevil?
Yes, of course.
Okay,
Yes.
Okay, so on the Up to Date on otitis media and article on treatment, they actually have 3 different articles. They have one on epidemiology, acute otitis media. One is acute otitis media diagnosis, which is, I think, the best of the 3. And one is acute otitis media treatment. And in Up to Date, they say we suggest that children 6 months to 2 years old with unilateral bilateral otitis be treated immediately with an appropriate antibiotic. Well, okay, if you need to do something immediately, it sounds important. Okay, so what evidence are they going to use to tell me when Cochrane says you don't need to use antibiotics because they're going to get better anyway? I'm wondering, well, why is Up to Date saying I need to treat with antibiotics immediately? And so I asked that question, and their answer was, well, they work better than placebo. Okay. Well, what evidence do they have that they work better than placebo? Okay. Well, they talk about a 2015 meta-analysis of 13 randomized controlled trials with 3,401 children and almost 4,000 episodes. Okay. Well, this randomized meta-analysis is the Cochrane library. Okay. So they basically took the Cochrane database and used it to support a different conclusion. And they said, well, antibiotics reduce pain they reduce tympanic membrane preparations. And I think this, I imported these slides so the things aren't actually showing up where they want to. And yes, they increased adverse events, and they left off, and they said serious complications were rare, but they left off the, their main reason is you should do it because they reduce pain, but they left off the numbers needed to treat the benefit. So basically, UpToDate is citing the exact same database that Cochrane used to reach a different conclusion. Okay, so if you're confused about what do the evidence-based research studies say that I should do, and you're confused, you're not alone. Okay, so essentially the Cochrane database is saying, why be so rushed? The glass is 90% empty, and the UpToDate says, hey, the glass is 10% full. What are you waiting for? Okay. So, I kind of liken this to years ago, there was, the women's soccer national World Cup soccer tournament was Holland versus the United States. So, here you've got the Cochrane database is out of Holland, and they're the ones that say you don't need to treat. And then UpToDate is American resource, and the editor for this was in Boston Children's. And in Holland, they treat, when they diagnose acute otitis media, they treat it less than half the time. Whereas here in the United States, 98% of the time, antibiotics are prescribed. So what I thought we could do is just kind of like, compare the two evidence-based resources and see which one makes the most sense. Just pretend it's a soccer game and bring that out. So, potential pitfalls in the Cochrane review is, how do we know these studies that they included, since everybody agrees that Cochrane had the best, studies, both UpToDate, what criteria did they use, and did they have a high threshold or a low threshold for diagnosing acute otitis media? And, did they use the best outcome measures, and are they statistically powered to compare rates of serious complications? So, in the Cochrane database, and then okay, now I'm going to transition to tympanometry. I kind of imported some slides just this morning, and it may appear a little disjointed here, but we also have a database, which is the American Academy of Pediatrics Guidelines. And this is kind of the approach that we're taking in the United States now, which is, our experts are saying, what we really need to do is focus on stricter diagnostic criteria, because if any physician can look in an ear and see some redness and call it acute otitis media, which is the way that they were in most of these studies in the Cochrane review, we may be treating viral infections with antibiotics. And if we're treating viral infections with antibiotics, it's no surprise that you need to treat a lot of kids to make one benefit. So in the United States, we're saying, well, why don't we focus on stricter diagnostic criteria? And we won't call it acute otitis media until you for sure has a bulging tympanic membrane from positive pressure from a purulent effusion. And we're going to say you have to do something such as pneumatic otoscopy or tympanometry to really prove that they do have that effusion. So this study comes from a secondary analysis of one of the ones in the Cochrane database. And I'm going to show you what I think is the best study of all of them to really shed some light on which kids need antibiotics and which don't. So this is a study that came out in pediatrics, and the initial study was part of the Cochrane database, but then this is a secondary study that came out in 2017, where they took 746 children, all in the age range where the kids most get otitis, the 6 months to 3 years old. And they performed pneumatic otoscopy and tympanometry on all of them. And of that 746, they excluded 387 as saying they didn't really meet criteria for acute otitis media. So now they're left with 319 kids that have that they felt really did have acute otitis media because they had 2 out of the 3 things to suggest milliliter fluids, plus they had signs of acute inflammation, plus they had acute symptoms. And what they did is they took these kids and they randomized them to either 7 days of amoxiclavulanate or 7 days of placebo. And they said, what we're going to do is we're going to treat these kids with the blinded drug until they get, our endpoint will be time to treatment failure, and we'll compare the two groups, placebo versus antibiotics, to see, who gets treatment failure and is there a difference in antibiotics versus placebo in that amount of time it gets there. So they define treatment failure as at any time in the seven days, if the parents think they're worsening, they said, okay, that's a treatment failure. We're going to take you off the study drug, which we don't know if that's placebo or amoxiclav, and we'll put you on open label amoxiclav for 7 days. Okay, if the parents didn't think they were improving by day 3, okay, you're a treatment failure. We're going to put you on open label amoxiclav, take you out of the study. If you perforate, okay, you're out of the study. We'll treat you with antibiotics. And if you get a severe infection in another location, again, we're stopping the study drug and we're giving you open label amoxiclav. Okay. And then they saw all these kids back on day number 8 when they finished the antibiotics, and they said if they don't see an improvement in the tympanic membrane, then they're going to consider you a treatment failure. And so when they got to the end of the study, they found that rescue treatment was needed before day number 8 in 6.8% of the amoxiclav group, but 33% of the placebo group. And then when they combined it with the tympanic membrane examination on day number 8, they found that in a total 31% reached treatment failure, 19% in the antibiotic group, and 45% in the placebo group. And this gave them a number needed to treat of 3.8. And so this is the lowest number to treat ever in any of the studies. And what it shows is, if you narrow down the number of kids you diagnose with acute otitis media to those who really have acute bacterial infection, you get much more bang for your buck in terms of prescribing the antibiotic. Okay, and then the really interesting part of the study was when they did the secondary analysis, and they asked themselves, well, what factor made it most likely to predict that antibiotics were going to work better than placebo? And that was when they asked, was there severe bulging of the tympanic membrane? And you can see the dotted line here would be, if there's no effect of antibiotic, then it would cross the midline here. And so you see when there wasn't severe bulging, antibiotics were a little better than placebo, but when there was severe bulging, antibiotics were way better than placebo. And so when you see a tympanic membrane that looks like this, 11% failed if they got antibiotics, 64% failed with placebo, giving them a number needed to treat for this group down to 1.9. So, if I'm a pediatrician and I'm talking to you as a mother and I tell you, hey, Sevil, I can give you this antibiotic and, at least 1 out of every 2 children that gets this, that has a severely bulging tympanic membrane are going to benefit from it, then you'd probably be like, okay, I'll take the risk of the, disturbing my GI flora. I would like the antibiotic and I would like to treat it. Okay. Because it makes sense to use antibiotics in this scenario. Okay. And then they also asked themselves, well, what of all the factors they measured, makes it least likely for antibiotics to work? And they found that when they did they did tympanometry, they found that 57 out of the 319 that had that they felt had acute otitis media had a peak tympanogram, meaning a type A or type C. And of these, only 14% had treatment failure. There were 4 that failed in the antibiotic group out of 32, and 4 that failed in the placebo group. And the number needed to treat here was 29, and you can see the confidence interval past the center line here. So you don't even know that, this number needed to treat at 29, it could be infinity. You don't even know if any of these kids benefited from antibiotics versus placebo. So their conclusion here is these results are directly applicable in clinical practice. Oh, sorry, I forgot to put my pointer in the right place again. These results are directly applicable in clinical practice. By withholding antimicrobial treatment from children with peak tympanograms, your type A and your type C curve, the use of antimicrobial agents and the development of resistance can be reduced without increasing risk for the child. So, if you have a mom who's worried about having acute otitis media and you can do a tympanogram and you get your type A or type C curve, which we're going to go over what those are in a minute, you can tell them, I can give, 29 kids just like your kid in antibiotics. At most, one will benefit, okay? And there's no guarantee of even that. And then I think, mothers who understand that would at least say, okay, well, I guess, in that case, it makes sense not to start antibiotics yet, and we'll see what happens in the next few days. Okay. So these are, the tympanogram that we use in the clinic. Since you may not have these instruments, I'm just going to kind of skip over how to do it and get to how to interpret it. But so tympanometry, another word for it is impedance audiometry, and it gives you a graph. So like any graph, we call this the y-axis, the x-axis here and the y-axis here. And if we understand what those are measuring, then we can interpret it. So the x-axis down here is pressure with regard to atmospheric pressure. So 0 is atmospheric pressure. You start measuring something at a positive 200, and then you get to positive 100. I think these are delta pascals, and then you go down to measure something at a negative pressure. So anybody want to guess what we're measuring on the y-axis at different pressures? And again, with not sitting across the table, just
I think it's the volume where,
so
we have on the y-axis.
Yeah, so essentially, you can say it's how well the TM moves, what the compliance is. So basically, how well does the TM move at a given pressure? Okay, and then the ECV up here, that stands for the ear canal volume, and that is useful to kind of make sure that you're, getting an accurate measurement. Okay, so a type, now I'm going to go over the 3 types of tympanogram. So type A is the normal. And in the United States, this may be, you may not have this type of football in Iran, but American football, there's the ball looks like this, and what football is called in other countries is soccer in the United States. But the kicker's goal is to kick this football in between the goalposts here. So you have to get it above the bottom of the goalpost and in between these two. So if you think of the little box here on the tympanogram right here, they start measuring compliance, and at positive pressure is not very good, but when they get close to neutral compliance, it says, oh, you got really good compliance here. And then when you start to make it negative, the compliance drips off. So this is a normal tympanogram because the kicker kicked the football far enough and it's in between the 2 goalposts. So any peak that falls between these 2 lines and above this line is considered a normal type A tympanogram. And that means you've got air on both sides and you've got good compliance at a normal pressure, okay? Now, a type B tympanogram would be as if the kicker kicked the football, but he didn't kick it far enough. So you don't get a good peak at any pressure you test. Sometimes you may see a slight rise. Commonly, you just see a flat line or something that looks like this. So this is what we call a type B tympanogram. And a type B tympanogram does not mean you've got acute otitis media. Nor does it mean that you've got otitis media with effusion, but having a large effusion is the most common cause of a type B tympanogram. Other causes of a type B tympanogram, if you got a perforation, you're not going to get the TM to move back and forth, so that'll give you a type B. If you got a pressure equalization tube that your nose and throat doctors put in there, that gives you a flat type B tympanogram. If you got a complete cerumen impaction where you can't get any air to the ear canal, you can get a flat type B tympanogram. But it's amazing, even with a mostly impacted tympanic membrane, if some air can get by it, a lot of times you can get a normal tympanogram. If your probe tip is obstructed, you'll get a flat type B tympanogram, or if you have a cholesteatoma or advanced otosclerosis, which you don't really see in kids. So the key is, this is where you really want to look at the ear canal volume. So if your ear canal volume is way too small, your tip is probably clogged. And if your ear canal volume is way too high, then you've got a hole, either a surgical hole or a spontaneous perforation. And if your ear canal volume is normal, then you've got a lot of fluid back there. It doesn't tell you whether it's infected fluid or not, or whether it's bulging or not, but it tells you you've got a lot of fluid there. Okay. And when you do have a lot of fluid in the middle ear space, it does give you a mild hearing loss of about 20 to 30 decibels on average. Okay, now here's going to be a little video here. This is American, whoops, okay, I got to go back to it. So let me see if I can get it right here. This is American football. So you can see the kicker kicked the football, but he missed. He went too far to the left, okay. So that illustrates what a type C tympanogram is you got good compliance, as you can see right here, but you only get that compliance at a negative pressure. And that's pathognomonic for eustachian tube dysfunction. Whoops. So, the pressure behind the middle ear, behind the tympanic membrane is negative. And so you can get good compliance there, but only when when the machine puts negative pressure in your ear canal. And that's very useful to confirm that you got eustachian tube dysfunction. When you think you have it and you do a tympanogram and you see a type C, it's very reassuring to you as a doctor because you're like 100% sure of your diagnosis. And it also goes a long way to pleasing that parent who is skeptical of your diagnosis. So mom thinks her kid has an ear infection. You see a retracted tympanic membrane. If you do this, all of a sudden you can say, Mom, see, look, the machine says it's not an ear infection, it's eustachian tube dysfunction. And a lot of times I'll see the mom, the tension goes out of her face and she says, well, I guess I can trust my doctor because the machine says the doctor's right, even though they don't necessarily understand it themselves. So, it's definitely a good way to avoid giving antibiotics to the kid who doesn't need them. Okay. This would be one where, the tip is goes to infinity where it's a circular disarticulation. I've actually never seen this, but if the little bones become unglued from each other. And then this is one with positive pressure where I just wanted to test it. So I did a Valsalva blue ear behind my ears, and this is my ear. And then 30 seconds later, I measured it again and the pressure went back to normal. Okay. So now I'm going to kind of cover some scenarios on how tympanometry can be helpful for you. Okay. There's four main clinical questions that I'll use it. First of all, should I prescribe antibiotics in this kid? Do they have acute otitis or me or not? I also use it if I have a kid with speech delay and I'm wondering who to refer to first. Or if you got that kid that they say they have ear pain and you look in the ears and they look perfectly normal. Or if you ever want to know whether a pressure equalization tube is in place. So in the first scenario, okay, maybe you looked in the ear and the tympanic membrane doesn't look normal, but it doesn't look that bad either. It's just kind of in the middle. Or maybe you can't see it that well because the kid's got some wax in there and you can see some of the TM. It doesn't look perfectly normal per the gray, but you don't see the pars cervix either. Or, you got that parent that really thinks their kid has an ear infection and, you're not convinced. Or you got a difference of opinion. So you got an intern who thinks one thing and the resident thinks another, or one of the residents thinks there's infection there and the attending doesn't. It's a great tiebreaker. So in that case, you do a tympanogram. If you can get a type A or a type C, then you can tell everybody, okay, the number needed to treat here is 29 plus. And so it just doesn't make sense to prescribe antibiotics for 29 kids with the odd chance that one kid may benefit. On the other hand, if you get a type B tympanogram with a normal ear canal volume, you do then know that got a large effusion present. Okay. Now it doesn't for sure mean it's acute otitis media, but I think then I usually punt, or I usually give in and say antibiotics are reasonable if the kid's got ear pain or fever, or the exam is equivocal. If I at least know I'm at least not treating eustachian tube dysfunction or normal ear, at least I know there's some fluid back there. So if any of these things are present and I get a type B and I'm not sure what to do and I couldn't see the TM well enough to know that there's not bulging, I a lot of times will say, okay, I'll go ahead and treat. Okay. Second scenario. So I've got I'm doing EPSDT is what we call our well child checks. So I'm seeing a small child for a well check, and they got normal looking TMs, but they don't have enough words. What could cause that? Well, serous effusion can be very difficult to see, and if you got a serous effusion on both sides and you're not hearing well, you're going to be speech delayed. And so if I do a tympanogram on a kid and he's got normal type A tympanograms, I'll send him to the audiologist for a full hearing exam. But if I get a type B tympanogram, I usually send them to the otorhinolaryngologist first, because if they've got serious effusions behind both ears, the audiologist isn't going to be able to do their best ear exam. And our ENT doctors can do a pretty good hearing test in their office too. So I'll let them get rid of the middle ear fluid first, and then we can do the full hearing exam. And here's just an example. This is back when we had paper charting. So this is a 2-year-old kid who came in where he only had 10 words. And then he failed his MCHAT, which is our autism screening tool. So it looked like maybe this kid was going to have autism. But I did a tympanogram on him, even though the TMs looked normal. And he had flat type E bilaterally. So then I said, okay, well, we'll see you back in a month and see if they get better on their own. And they came back in November. He didn't have any improvement. So we sent him to the ear, nose, and throat doctor. They saw him in December. They scheduled them for surgery. He still had flat tympanograms. They scheduled them for surgery in January, put in some tubes, and then they saw him back in February and sent us a nice letter saying, hey, his caregiver says he's speaking a lot more. So this is an example of a kid that initially we thought was going to have autism, but instead he just had serious persistent effusions that kept him from hearing well. And when those got cleared up, then he had his number of words he knew and amount of speech that came out of him improved quite a bit. Okay. So third scenario, you've got a kid who's complaining of otalgia and you look in the ears and they look perfectly normal. Okay. So how can a eustachian tube help you out? Well, if you do one here and you get a borderline type A or type C tympanogram, well, you've just diagnosed eustachian tube dysfunction, and then you can tell the mother, okay, that's why your kid's complaining of their ears. They feel the pressure there, and that it does cause discomfort. And then you don't need to give antibiotics for it, and you can tell mom the natural history. Okay, so it explains the complaint, and then if you can follow them up a month later, and if they still have persistent negative pressure there, at some point you can send them to ear, nose, and throat, because that's one of the ways you get retraction pockets is if you have eustachian tubes that are chronically clogged. Okay, on the other hand, if you get a type A tympanogram bilaterally, you can tell mom, reassure her that your kid's ears are perfect. But if they're complaining of teeth pain, be sure to ask about, do they grind their teeth? Because your kids that grind their teeth at night, your TMJ joints are right here, your ears are right here. Kids with TMJ pain never say they have TMJ pain. They say they have ear pain. And you look really smart as a pediatrician if mom comes in thinking her kid has an ear infection, and you bring out a machine and the machine says, no, you got eustachian tube dysfunction. And then you ask her, does your kid grind their teeth at night? And mom, jaw drops, is like, how did you know my kid grinds his teeth at night? It's terrible. And you say, okay, well, what your kid has is TMJ pain, and it's from the, grinding their teeth at night. And then you can treat that. And as a pediatrician, you look really smart for making the diagnosis. So, and then the fourth
to my mom, actually. I'm sorry, I'm interrupting. Yes, after 6 months, we could find out what's the problem. It was so close for her to have surgeries, and then we understood, okay, it's TMJ, no big deal, and it was okay. But as a pediatrician, I've never seen such a thing, and of course, I've missed so many.
Yeah, the pediatrician that taught me this, he himself had TMJ, so he was pretty quick at picking it up. And so yeah, it's usually a school-age kid that comes in, they can talk. They say, mommy, my ears are hurting. And the moms always think it's the ear problem until you, and so that's when a tympanogram is great, because if they look normal and your tympanogram is normal, then you can be 100% sure that they're normal. Okay. And then a fourth scenario, if you ever want to know whether a pressure equalization tube is in place, it's good to know typical ear canal volume. So an infant, can be anywhere from 0.3 to 0.9 mils. Adults are usually 1.5 to 2 mils. So if you do a tympanogram on a kid with a PE tube who doesn't have otorrhea, and you get a large ear canal volume, well, then the tube is patent. And if they got a tube and they don't have otorrhea, you can be certain they don't have acute otitis media. And if you can prove their tube is patent and they have otorrhea, then you can give topical antibiotics and get a much higher concentration in their ear of ciprofloxacin or ofloxacin than you can by putting amoxicillin in the mouth and having it go to the stomach and diffuse into the bloodstream, and then go to all the capillaries of the body, and hopefully some of the amoxicillin diffuses out into the fluid in the middle ear space. Okay. And then if you want to follow up acute otitis media after acute otitis media, always ask the residents if they know how long it takes for middle ear effusions to disappear after acute otitis media resolves. And they usually guess, and they get them about right. So it's the studies show at 1 month, 40–50% still has the middle ear fluid. By 3 months, it's usually gone. So kind of our rule of thumb here is if you got, if you got fluid persisting in the middle ear space beyond 3 months, by that point it becomes more viscous. It's less likely to resolve. So I'll always send them to ENT after 6 months, and I'll certainly consider it even after 3 months if it's bilateral, especially if it's coming up on respiratory season, more likely to do it. And if we're coming up on the summer where kids are better, I may wait a little longer. And then there's an AAP, separate AAP guideline for dealing with OME. And they recommend that we always, check at least every 3 to 6 months to make sure that middle ear effusions go away, even in kids, no risk for delays. So in our clinic, we usually don't, if we diagnose acute otitis media, we usually don't see them back right away if they're younger too, and they're going to have a well check sometime in the coming months. But after they're 2 years old, and we're not going to do our well check until 3 years old, then if I see a kid with bilateral acute otitis media, I probably wouldn't want to see them back in a month or two, just to make sure that their fluid is going away. And I wouldn't want them to come in 11 months later and find out they'd had bilateral effusions for a year and now have speech delay, and I didn't do anything about it because I didn't know about it. Okay, so I'm just going to go through the couple slides there on the companion. So now I was going to like to close with some real videos. So again, if our audience response was working, I would have you all vote and make it into a game, but I'll go through it anyway, but at least you can see the video. So this will be the first video, and if people can add to the chat, you can just put in there, your choices are, is it a normal ear, and put in whether it's left or right. So is it normal, is it acute otitis media, AOM, or is it OME? And so anybody who's brave enough, go ahead and add things to the chat.
I think it's left, isn't it?
Okay, are you seeing it?
Yes, I'm seeing this.
Okay, okay.
And
So
this
I'll
should
let
be
it run a
the
little bit.
left ear.
Yeah, very good.
Making-
So it's left
yeah.
ear, because there's the umbo there, and the malleus is going up to left, the condylar is going down to the left. Don't pay too much attention to the color here. They all look kind of reddish.
Yeah. Okay, Megan says it's normal.
Yeah, so this would be the quiz. And you were right, it was all normal here.
Okay, thank you, Megan, for your
Okay.
participation. Everybody come on.
Yeah, okay. And so here's the second ear.
Huge cervix.
Yeah, okay, you got it. And so that was a
Right, AOM.
right here, yeah. And this, you can see it. So
Bulging.
this would be the umbo right here.
Bulging.
There's certainly nothing up here that looks like a malleus crease, and the creases show up better when you're looking through an actual otoscope than they do in video, but there would be a crease there, and I'm looking up here where the short process would be. And even when they're insufflating, I can't see a short process sticking out. Oh, that's something I think I forgot to say earlier is I'll use if you can look right here, say this is the short process in a normal ear. When we're trying to decide if you got mild, moderate, or severe bulging, if this is normal, with mild bulging, you kind of see the short process getting less and less conspicuous. Moderate bulging is when it's kind of gone, but when you're insufflating, you're seeing it stick out. And then severe bulging is even when you're insufflating, you're not really seeing the short process much. So this one I would categorize as severe bulging, because even when they're insufflating here, I can't see anything that looks like the short process. So that's one we treat with antibiotics. Okay, so next one here. Whoops, okay. So I'll give you a few seconds to look at this one. So I'll just go ahead and give you the answers because we don't have the audience response. So you can see.
Does this one have mild bulging in the flaccid part?
Okay. So here you can see the whole malleus right here, and here's the short process right here. What you can see is there's an air bubble here, air bubble here, air bubble, and you can see when they insufflate, they're moving around. So you know you've got an effusion. If I look right up here, I'm not seeing any bulging here.
Mm-hmm.
So this one would be The right answer here would be a left otitis media with effusion. So this one wouldn't get antibiotics. Okay, so now we'll go back to this one. So, okay, here's number 4. A few times, so again, malleus right here, malleus going up to the left, short cross, cone of light going down to the left, so we know that's a left ear. This one is neat because it's got this, you can see how this little part right here is moving with the insufflation. And now look at this part right here. You see how that's not moving? So you can ask yourself, well, what is that? This right here is the incus that's behind the translucent tympanic membrane. And so when you insufflate, the incus doesn't move because it's not touching the tympanic membrane. This is just a little thickened part of tissue. Doesn't have any name, but you just see it moving right there. So anyway, I'm seeing the left tympanic membrane. You got nice brisk movement. You can see the incus through it, so you know it's translucent. And you don't see any air bubbles. So this would be a normal left tympanic membrane. So normal left. And now we're on to our next one. You see, you got some injection here. You got kind of the whitish, milky, cloudy, opaque color. You can see that this one would be more mild to moderate bulging because you can see the short process right there, but you can see it's definitely started to bulge right here at the short process. And, it's not quite the cervix yet, but it's on its way there. So this would be, and again, elbow malleus going up to the right. So this would be your, whoops, yeah, okay, this would be your right acute otitis media, but not as severe bulging as the first one. And okay, so here's the next one. So that's enough. So again, umbo in the center, malleus going up here. No evidence of any bulging here. Short process is, in normal position. So is the cone of light. So it'd be easy to say it's normal if you didn't pay attention to this air bubble right here. So when you can see the air bubble moving a little bit, that means you've got fluid behind there. But again, so this would be a right otitis media with effusion, OME. So you would not treat it with antibiotics. But it would be, but again, if you miss this effusion, it's not a big deal because you weren't going to treat it with antibiotics anyway. So there's probably a lot of these we may look in quickly, say it looks normal, and that's perfectly fine to miss an OME because you're not going to necessarily do anything about it. Okay, so that was a right OME, and now I've got 3 more. Oh no, that's the same one. Okay, so here's one. So here you can see the very crisp, brisk movement. Again, so that'd be umbo right there. You can see incus behind the tympanic membrane. Whoops, okay, go back. I'll just show it again. So you can see how crispy this moves, and that's your short process up there. So the malleus and short process. And again, I see no air bubbles here. So we can call this a normal one, and certainly we're not giving antibiotics to it, even if there is a small effusion back there. So right, normal, and then these last 2 are kind of interesting. Okay, so look at this one for a while and see what you can notice. Okay, so to start with, is it left or right? Well, we'd say, okay, this probably would be where the umbo would be. So this is, this interesting stuff is going up to the left. So we'll say it's a left tympanic membrane. And then this is one where the doctor who made these videos didn't have the benefit of Dr. Pekikiro showing him where to put the camera. So I really wish he had put the camera up about right here where the short process would be. But he didn't. So, but it looks, without seeing the short process, it's hard to be definitive, but it looks like it's kind of got the donut, cervix shape, and that's going up. And then you can see this right here, and you probably will notice, okay, that looks like a pressure equalization tube. And then you ask, well, do the ENT put them through the malleus right there? And the answer would be no, that's not where they want to put them. So this one has come out because if it was in place, you would have pus leaking out through it. So it just come out, it's got stuck in some wax, and then this little scar here, that's where the tube was once upon a time. So it's come out, just got stuck in some wax. And so the best answer for this one would be that you've got a left acute otitis media, even though you can't completely see the top of the short process of the malleus. And then here's our last one. And again, this would be a left impending membrane where I wish you would put the camera up here, but you can very briefly see that it looks like you see the bottom of the malleus right here. And this is interesting because you see an air bubble with cloudy fluid there. And so this is one where, some people would say, hey, it looks like you got pus back here. There's definitely fluid. Some people may want to say, well, I want to call this acute otitis media. But if you can see the the malleus right here, and it looks like it's not bulging, especially if you could look up and see the normal short process, then if it's not bulging, it would be one where you'd say, well, it doesn't meet criteria for acute otitis media. And then you could ask yourself, well, how did the ear get this way? And this is where the history would really come in. So let's say this kid was diagnosed 10 days ago with an acute otitis media. Well, then I would say this is exactly what I would expect 10 days later. The fluid is starting to drain out, air is coming into the middle ear space, the bulging is gone. This is normal resolution after an acute otitis media. On the other hand, if I saw this kid 2 days ago and he had normal ears and now I'm seeing all this fluid there, I could say, well, maybe it's not bulging yet, but maybe in another 24, 48 hours, it will be bulging. So in that case, I'm, in the States, we sometimes call it a safety prescription. And sometimes if it's a Friday and, you might say, Mom, okay, here's a paper prescription. I want to start this antibiotic right now, but if sometime in the next couple of days your kid gets really bad ear pain, then you can go ahead and take this to the pharmacy and get it filled without another appointment. So, I think this here very well illustrates one of the take-home points is, before you have otitis media with effusion is kind of like the tip of the iceberg. And before you get, acute otitis media is kind of the tip of the iceberg. So before you get acute otitis media, you always have to have OME before you get the bulging. And then you're always going to have fluid left over after the bulging resolves. So if you kind of think of the natural course, and acute otitis media can resolve on its own. Even without antibiotics. And in the days before antibiotics, lots of kids got otitis and recovered on their own. So otitis media with effusion is just kind of like the tip of the pyramid. And at that point, antibiotics are indicated, but you're going to have OME both before and after. So that last one was left OME. And I think now we are at the end of the lecture. So I think we've got, if you want to stick to the 2 hours, I could take questions for a few minutes. If you want to put them in the chat or turn on your cameras and speak up. But that's all we got for today.
Thank you so much. It was amazing. At the end of the lecture, people were participating. I would thank everyone, state medical stagiaires, medical interns, residents, and we had Dr. Zandaru with us, our infectious disease doctor, who was participating in the chat section. Okay, guys, if you have questions, you can turn on your camera, you can turn on your microphone, or you can write in the chat section. And we would wait a few minutes for the questions. And I'm going to ask this question one more time in Persian for those guys who have missed this. عزیزان ممنونم که شرکت کردین. اگر سوالی دارین میتونید میکروفون و ویدیوتون رو روشن کنید یا به چت بنویسید. حتی اگر فارسی باشه من ترجمه خواهم کرد. And everybody's thanking you. And I'm going to tell you, I'm going to make big changes in that hospital with, removing the cerumen, with performing the nematoscopic otoscopy. It's very, very important, and I will seek some help from you, of course. So I don't see any questions in the chat box. Let me check one more time. And I myself have one question. Do you perform tympanometry at any age, even in the infancy?
But yeah, that's a good question. I forgot to say that. You have to wait till they're about 7 months of age, because under too young, their ear canals are too compliant. And so it doesn't really work. And you also have to have the child still. meaning a child can be crying, but if they're crying and fighting, you just, the instrument can't really give you a reading. It's just noise. So
Okay.
anytime you're doing tympanogram, if you want to get a nice, single peak. If you get more than one peak, that's all noise artifact. And so if a kid's really fighting, you can't really do it.
Thank you. And Mojda have a question. Do we have AOM in neonates?
In neonates? Okay.
Yeah,
That's
neonatal periods.
Yeah, good question. It's really rare to ever have acute otitis media before you've had your first viral respiratory infection. So yeah, I have never diagnosed acute otitis media and probably never before 3 months of age. Now could you theoretically, if you were born today and somebody gives you a cold, 2 weeks from now, could you have theoretically speaking, could you have acute otitis media at 3 or 4 weeks of age after you've had a cold for a while? I guess you could. Here in the States, any fever in a child under 2 months of age, they get a full workup in the ED with blood and urine cultures and if they look sick, even empiric antibiotics sometimes. So we don't commonly diagnose acute otitis until usually more like the 6 months to 2 years age is when we diagnose the most. But if I saw a tympanic membrane and a 3-month-old that looks just like a cervix, and I could see good enough and I was sure of it, then yes, I think I would be willing to say, okay, you just have an acute otitis media and here's a prescription for amoxicillin versus anything else. But if I thought a 2-week-old had a bacterial infection, they would be hospitalized.
Okay, and one of our friends have asked, how about premature? There may be premature neonates, and with a history of hospital admission, premature neonates with the previous history of hospital admission, do they get acute otitis media?
Okay, I didn't catch everything you said, so can you repeat it?
They've written, how about prematures, neonates being born before the 37 weeks of age with previous hospital admission, for example, in an ICU.
Okay, yeah,
Do
so that's a good question.
Get acute otitis media?
Yeah, I don't I don't work in the NICU here, so I don't imagine that they really diagnose acute otitis media in the NICU. And again, the kids in the NICU should be pretty much free from respiratory viruses. So I would say diagnosing acute otitis media in a kid who's never had a viral respiratory infection with a snotty nose is probably pretty questionable.
Okay, thank you. And I have another question. How do you follow up those kids who have some degrees of hearing loss after treating acute otitis media else than tympanometry? Do you perform other type of audiometry, for example, ABR or something?
Okay, that's a good question. We have, we may be spoiled here, but we have audiologists in our hospital. So anytime we suspect hearing loss, we just, I mean, there's some instruments that we use for screening in our general pediatric clinic that you can, test hearing in the nonverbal kid. And so we normally screen kids. I mean, in the United States, every child at birth, they get a hearing test before they leave the hospital. And then they get screened when they come in for their well checks on a periodic basis.
Yeah.
But then if they fail the screening or we have any concerns, we just send them to the audiologist, and they have a hearing lab where with toys and flashing lights, and they can kind of see if the kid, even kids that don't talk yet, if they put headphones on and they see a little, they hear a little sound and they look to the light, then you know that they're hearing that sound.
Thank you so much. We perform that kind of audiology test for neonates being born at the very first step of their life too. So I don't think I see any other questions, guys, in the chat box. If there are any other questions, I'm going to thank you. Thank you very much. It was very, very educational for me.
Okay.
And I hope this kind of cooperation continues. I have so many questions. I need to do so many things at our hospital based on these lectures. Thank you so much. Thanks, Dr.
Okay. I
Tavasoli,
just wanted
for
to say thank you to all
arranging
the,
this agreement.
okay. And I'll just say thank you to all the people of Iran from the people of the United States. We're all brothers and sisters. We live on the same planet, and you know, don't we know that when we watch TV, not to believe everything we see in other countries, and hope that you all also know that whatever, I don't know what the TV in Iran and the news shows about the United States, but it's not really representative of the people that live here. So
I'm sure that it's
okay.
like that. And that's why I'd never ever watch TV. And I suggest guys not to watch TV. Just
Yeah, I'm one of the 1% of Americans that does not have a TV at home too.
yeah, okay, that's the best kind of, you know, lifestyle. And I hope this cooperation continues. Thank you so much. Despite the time difference, you managed to have this session. And from all my colleagues at the hospital and at Pediatrics Group of Tehran University of Medical Sciences, I give you a great thanks. I think we are going to say goodbye, but I really do hope we can say hi again.
Yeah, you all can eat dinner and I'll have breakfast.
Yes, of course, we're going to have dinner on the weekend. Thank you. Good morning to you and good afternoon to our guys. Bye-bye.
Bye-bye.